The many myths of IT band pain. Stretch it, crush it, fix the friction. Stay tuned to find out more. Prehab, welcome back to the channel. Dr. Dorian St. Danik here, and today we will be discussing IT band pain. We will cover relevant anatomy and function, causes of IT band pain, and rehab strategies. If you've been working through IT band pain, you may have been told that your IT band is tight or that it has adhesions, and that with this anatomy, your IT band is catching back and forth over the distal end of your femur. However, newer research shows that increasing stiffness of the IT band is actually correlated with positive improvements in recovery, and that the pathoanatomy of IT band pain is compressive as opposed to friction-based. As opposed to mechanical deficits, this compression-based injury is the result of errors in training load, doing too much, too soon. Let's dive deeper into what the IT band is. The IT band is a thick band of fascia or connective tissue that originates at the ilium of our pelvis and inserts into the lateral tibial plateau of the tibia. It's an extension of our tensor fascia lata muscle, and it shares muscle fibers with the gluteus maximus. This connection is important as it dictates which muscles and movements we should train in order to improve the tolerance and capacity of the IT band. The IT band has firm attachments at the femur and the patella, dispelling the myth that it can actually shift back and forth as the knee bends and extends. So the role of the IT band is threefold: tolerate high loads experienced at both the hip and the knee, resist varus stress, which includes lateral or side-to-side forces, store and release energy during activities such as running and walking. IT band pain is likely derived from nociceptive or pain-producing properties of adipose or fatty tissue that sits between the IT band and the femur bone. So we experience compressive stress of that fatty tissue at 20 to 40 degrees of knee bend, such as during walking and long strides. It's important to remember that it's not actually the compression of that fatty tissue that's pathological, but rather the training loads that came on too high or too soon, causing sensitivity before our tissues could adapt. So the symptoms associated with IT band pain include pain on the lateral outside of the knee that occurs when the hip extends behind us and the knee bends, such as walking downstairs or taking long strides. Risk factors and causes include runners who rapidly increase their running volume, speed, frequency. Simply put, we exceed our knee's capacity to absorb, manage, and produce force. Biomechanical considerations can play a role, such as taking part in downhill or trail running, which causes a more narrow stance as well as elongated stride lengths. Lastly, stress shielding. The runner who experiences IT band pain will stop running. Their pain will dissipate, but their capacity will lower. Once they go back to running at their previous duration, distance, and speed, their cup is smaller, so they have inhibition of some muscles up the chain, their capacity is less, and now they repeat the cycle. So now that we know a little bit more about the anatomy of the IT band and what's causing pain in that lateral knee, let's go over what you can do about it. So let's start with the early phase of pain management. If symptoms are more irritable, let's say 5 out of 10 or higher with sport or daily activities, we want to begin in this pain management phase. So this will include activity modification and load management, soft tissue manipulation, isolated therapeutic exercise. So if we get pain experienced during running, minimizing or avoiding downhill or trail running can allow us to continue participation. Let's say flat ground running is compromised. Incline treadmill running or brisk walking can be a valid option to continue conditioning. Another strategy to modify running is to increase your cadence or step rate anywhere from 3 to 10%. This will help decrease stride length and increase step width, lowering overall strain on the IT band. You can learn more about running by checking out some of our other running videos, as well as our Running Prehab program. Check it out here. So, foam rolling, stretching, scraping, do they work? Well, yes and no. It's not going to change the length of your IT band, nor will it break up any adhesions or fascial restrictions. So these sensations of tightness, stiffness, pain can all be minimized with soft tissue manipulation, but through a mechanism of centralized pain modulation. That is, your brain becomes more in tune to the more immediate stimulus, that stretch, that pressure, as opposed to the sensitivity of pain in the IT band. So does foam rolling play a role in IT band rehab? Well, if it gives you a window of opportunity to begin loading, it can be a useful tool. You can learn more about foam rolling by listening to our podcast. Check it out up here. There is a better way to foam roll your IT band. Remember back to the anatomy of those proximal attachments at the tensor fascia lata and the gluteus maximus? Well, we can actually target those areas to get relief from our unpleasant sensation, the pain in that lateral knee. Try this variation of foam rolling to go after structures that aren't quite as dense with nerve endings and have actual relaxation properties that can help with mobility at your hip and at your knee. Shoot for 90 seconds and stay in a small surface area. Open chain and partial weight-bearing exercises that target hip extension, abduction, and external rotation can be effective introductory options to begin improving endurance and strength capacity of the IT band. The loads are relatively low, so they should be tolerable. Let's keep these at a 2 out of 10 or lower pain rating. One exercise we prescribe is the single leg bridge with opposite knee to chest. This one helps build capacity of the gluteus maximus muscle while actively improving the mobility of your hip extension. This exercise also has excellent carryover to optimal use of the glute during walking and running. Work through extended isometric holds of 30 to 60 seconds or volume of 15 to 25 reps. Our goal is targeted muscle activation working towards muscular fatigue. Another excellent option is side-lying hip abduction with core activation. This variation locks out the pelvic girdle, allowing for more targeted hip extension during hip abduction. Once again, we're dosing with extended duration and higher volume. When we're able to take long strides or walk downstairs without pain, we feel more confident to progress into the next phase, strength training with progressive resistance loads. We will perform these at a slow tempo so as to adequately load the intended structures through the entire range of motion. We recommend a 6-second tempo with 3 seconds to descend and 3 seconds to ascend. The rear foot elevated split squat is an effective mid-phase exercise option as it loads both the gluteus maximus and the tensor fascia lata in a hip extended and knee flex position, exactly the motion where the IT band is under greatest strain. Focusing on an upright torso to keep more weight in the rear leg emphasizes the load demands where we want it. Begin dosing at 15 repetition maximum, working towards a 6-rep maximum over the course of 4 to 8 weeks. Perform 3 sets each session, 3 times per week. As we begin to improve our tolerance of high loads going through the IT band, we feel more confident to introduce plyometrics entering our late phase. An excellent plyometric exercise option is lateral bounding, also known as lateral skaters. These exhibit high levels of gluteal activation. These movements also store and release energy and resist that varus stress, both key physical qualities demanded of the IT band. We can train these under power demands going for maximum distance during performance. Typically, we dose these to train reactive elasticity, dosing anywhere from 10 to 30-second bouts, aim for 3 sessions per week, and we may only stay in this phase for 2 to 4 weeks. Since it's likely that running got us into this situation, we need to be methodical and specific with our return to run programming. Exploring incline running, running with increased cadence, and running intervals with specific distances or durations allow us to control for loading that comes from running. We need to treat return to running with the same organized plan as our progressive resistance exercises. We can also phase out our plyometrics as we introduce running, but we want to aim to keep those heavy, slow resistance training options once a week in order to tolerate high loads at the hips and at the knees. All right, let's wrap this up and discuss some of the key takeaways regarding how to rehab IT band pain. So the early phase includes pain management in the form of activity modification, load management, soft tissue mobilization, and partial weight-bearing therapeutic exercise. The mid-phase encompasses progressive resistance exercise under heavy loads and slow tempos. The late phase transitions to plyometric exercises and activities aimed to gradually build tolerance to the rate and frequency of loading at the IT band. If looking to take the guesswork out of rehabbing your IT band pain, check out our Running Prehab program through the Prehab app. Until next time, Prehab, take care.
Hey, did you like this video? If you did, you should definitely check out the Prehab app. It includes all of our programs, a brand new workout library, and tons more videos like the one you saw today. Check it out by clicking on this link. You get a free trial, Take control of your health today.